everyone. I'm very excited to welcome Dr. Helen Odell Miller as our next interviewee in the series 2020 to 2023 for the World Federation Ethics Commission. Dr. Helen Odell Miller is a researcher and clinician in music therapy. She is a professor of music therapy and director of the Cambridge Institute for Music Therapy Research at Anglia Ruskin University in Cambridge, United Kingdom. So with that, let's welcome Helen and let's get to know a little bit more about you. So I'm hoping you can tell us, Helen, about some of your research and give us an overview.
Yes, thank you very much. I'm really pleased to be asked to do this interview. I started researching in my first clinical job, which was in the learning disability field in a hospital run by the National Health Service in the middle of the 1970s. And very early on, I had questions. I thought, I can see this is helping people, but why? And in those days, there wasn't so much evidence, and there weren't so many articles and projects out there. So my first project was in setting up a steering group and asking the question, how would the service, which was a big service where people lived with learning disabilities, how would the service prioritize referrals for music therapy? And that was not published. I would urge everybody to publish everything. I wish that we had. It's just a hospital document, but actually I think it showed that the priorities related to people who had communication difficulties. That's probably not surprising nowadays for people, but and particularly those who found it difficult to communicate to others using ordinary spoken language. Plus, of course, a more in-depth emotional aspect sometimes to the referrals, but it did help with a new service in thinking about how could the service best benefit the people who needed the input most. So one could say that was an audit, but we did have some quite specific research questions. From that, I moved into the field of adult mental health and child and adolescent, and working with people with dementia as well, the whole spectrum. And in that service, we're talking about services run by our National Health Service in the UK, where we're lucky that people who are researchers are employed, even though it's a health service, they're always attached to a university. So being in Cambridge, there were people who had posts as psychologists, psychiatrists and others who were very familiar with research practice. And in the days when I trained as a music therapist, research methodology wasn't embedded in basic training as it is now. So the next project was relating to people living with dementia. And I would also say that if you want to do really robust research, it's good to connect with the university. So not only did I have this team of clinical psychologists and nursing staff and others who were able to advise and supervise, but I enrolled for a master's, an MPhil in fact, at City University, where Leslie Bunt actually was one of the supervisors, although we were colleagues and we trained together. He'd already embarked on his PhD. So I would say what was helpful there was to design a study where the questions were about how engaged were people living with dementia in music therapy sessions, and how different was that in talking therapy, more like reminiscence therapy. And that study is published in the Wigram, Sapperston and West, The Art and Science of Music Therapy book, in a chapter. And it was one of the first controlled trials for researching people living with dementia. And these were people at the end stages of living with dementia. So out of that, it was an observational study where we defined engagement and then coded the different aspects of it, which involved eye direction, musical interaction, at different levels of engagement, and then looked at those in sessions where the same group of people were looked at having reminiscence talking therapy, which involved sometimes looking at pictures and other things, and music therapy. And we found that the mean levels of engagement were higher for the people living with dementia in the music therapy groups and in the reminiscence therapy groups, but not statistically significantly. I can say more about that. But this led to an increase in posts. It was convincing enough for the National Health Service to decide they wanted to put some funding towards a full-time post only to work with older people, whereas the original post I had was working with people across the board. So I suppose what I would say is there's so many reasons for doing research, but in the early days, it was to find out more knowledge and especially to help people. We could see it working, but often medical or other colleagues needed much more robust, collected, systematic evidence using numbers, using qualitative and qualitative outcomes. But also, this data could be also used to convince employers. And I think that's still the case. So I think there might be many reasons. And when you do research, you should always sort of be clear about the reasons and who you're doing it for.
But all of what you're saying is so rich, Helen. I mean, some of the key things that stand out for me, it just resonates with me in terms of my own teaching. When I teach research methods to the graduate students, I always ask them, to think about their clinical work and to think about what's happening in a session and why something is happening or why it isn't. And that's where I think some of the best research questions come from, when we want to learn why what we're doing is having an impact or why it's not having an impact, so that we can change our practice.
Yes, that too.
And some other words of wisdom from you in terms of publishing your work. I think that it's essential, right? There are many people doing wonderful work. And so the publishing will only help to advance our profession. And what an amazing result from your research that generated more job opportunities because they saw the efficacy. And I think that sometimes that is really helpful in growing our profession in areas where the profession is a little younger. Yeah, yes. So that's all fantastic.
I could add one thing about the publication, which is I was very lucky to be invited by Wigram and Tony Wigram and Saperston and Robert West, to contribute the chapter to that book. But because of that, it was my first big publication. I didn't publish that research in a journal, in a peer-reviewed journal, which nowadays I think is very important. And I also didn't put some of the important keywords in the title. So it's actually called, the title is about elderly mentally ill people, which a term you wouldn't use now. But it doesn't really come up in searches. So I would say that's another piece of advice to people, to think about how your work will come up in the right fora. Not that that's always, but it is important because it's, if you've done a piece of robust research, it's good that other people, definitely outside of the music therapy profession as well, can access it.
I completely agree. I think your point even about interprofessional collaboration is so timely that I think one way to obtain larger grants to help us do research is often when we are in these interprofessional teams and each person has their own specialty, so can really help to create a very robust research study as well.
I've always been interested in trying to get at the mechanisms, the processes that are happening. So as well as looking at the outcome. And I'm very keen now on mixed methods studies, where you can both use some robust, already sort of accepted statistical methods that, by the way you arrive at the numbers is also has, in my view, a subjective aspect to it, because often it's the clinician or the person themselves that actually evaluate the answer for this question about what are the components that are changing for you, or but I think it is good to collect that sort of numerical data, but equally at the same time not to miss looking at the nature of the relationship and the nature of how music is working. So in the adult mental health field, which I then moved to, we did a big study that's published in the journal Psychotherapy Research. And we asked some huge questions. And this was across a whole arts therapies service. So I suppose that's something else that we did. It was published in 2006, but the work was done a few years before that. And compared with, I suppose, some of the work then going on, this was one of the first studies that looked at all the arts therapies together, which is now coming back into focus. Recently, just last week or the week before, there was a publication of an article which is about mechanisms of change in the arts therapies by a group of arts therapists. Felicity Baker was one of the music therapists involved. And so I think that another interest is about the different mechanisms that there are in music and in art and in drama and dance movement. So I suppose that could be something unique that I'm not necessarily focusing on now, but in the 1990s and 2000s very much did, because I worked in a service where we developed all the arts therapies. And so in that study, I would say people were in the study and they were randomized to having an arts therapy or being put on a waiting list. And I would say quickly that we started with 42 people as part of it, and we could only use the data of 26 because people moved away, they decided it wasn't for them. These things happen. And I would say as well to everybody, this is okay. This is part of research. This is telling you what happens for people living with these issues, and the dropout rate can be quite high for some populations. So I would just say to anyone concerned about that, just to accept it. You set up a research project and anything can happen. And that's the most interesting thing. So out of that, what we found instead of huge change across time, we were trying to look at the mental state changes for people having arts and any arts therapy, as opposed to people not having an arts therapy but having ordinary care. Well, we had too many variables. We had 4 different therapies and people across all the diagnostic categories. So already you could say, well, would you have found anything significant? But this was about a service, and we wanted to do a research project that was about the real service as it was delivered. What we found instead was we did a qualitative part. So mixed methods, as most of you will know, is a combination of a more numerical outcome, number-based, quantitative type of study, or there are different terms now that Barbara Wheeler and her colleagues have termed in the Music Therapy Research most recent edition, but anyway, more traditionally known as qualitative or quantitative. And the qualitative aspects are getting at the rich nature, people telling stories, telling their narratives. So that part of the study, we interviewed the participants about what was asking 4 questions in a topic guide. What was the unique benefit of the arts therapy, if any, that's different to other treatments that you've had? Was there anything particular about the relationship with the therapist? Was there anything particular about the art form itself? And were there any changes that happened? And from that, this may seem a small outcome. For that, we had data from only about 10 participants across the different arts therapist forms. But all 10, as you'll see if you ever sort of read this article, I'll give the title in a minute, showed that unique elements were the fact that there was an art form and that there was active participation between the therapist and the participant using this art form that was different and unique to other ways of being. For those that perhaps hadn't found the therapy so useful, there was an agreement between the participants' narrative and their view of it and the therapist. So the other thing we did in the qualitative data was we did interviews with the therapists and asked them about the same participants, the same questions. And there was total agreement. So for one, the therapist said, actually, I'm not sure if this was the right time for that participant to be having this therapy. But the participant's view was the same. So what we found, which again may seem not very significant, but that at the time I think was quite important, was that the therapist and the participant's views of the experience of having the therapy coincided. But we didn't set out to ask anything about those particular aspects, but that's what we found from this study. And it's called an investigation into the effectiveness of the arts therapies for adults with continuing mental health problems, Odell Miller, Philip Hughes and Mark Westacott. And that's a multidisciplinary group. I'm very keen on multidisciplinary research. So that's a psychologist and a music therapist, research assistant, and me.
Thank you. That sounds very interesting as well in terms of, combining. For me, I'm very much a mixed methods researcher because I do strongly believe that that mixed methods helps us to counteract some of the issues when we have only a quantitative or only a qualitative study. Although I have done quantitative and qualitative. But I do find that many of my more recent studies have been mixed methods, and that they do, as you said, generate that rich kind of understanding of experience while we have the numerical support. So it's interesting. I think you sound very much, or you resonate very much with my own research in terms of really desiring for that experience as well of the participants. So a lot of, my studies have also been phenomenological, where it's really trying to understand what it is like for that person in the therapeutic process.
Yes. And so I suppose I really, as someone who's been involved in 2 big international RCT trials, randomized controlled trials, should talk about that. Talk about those, because you asked about where the research sits in the international field. So through an international music therapy research consortium of different universities, we designed a study, Tony Wigram, Christian Gold and I and some others, many years before the Time A actually. We designed a study that didn't get funding, put it into the NIHR in the UK, but that was quite similar to the eventual design of Time A. But I suppose what I'm saying is that study and that wish to look at what was happening for children and families living with autism, where music seemed to have such an important role to play for particularly building relationship and understanding of the other, and arising from the really important work Monika Goretzka has done. Well, she did this pre-study that was trying to capture the elements that are needed for that work using improvisational music therapy. Interested us in the UK in particular. So and this is interesting. So we didn't take part in the Time A original study, but later the Time A randomized controlled trial group that was running across several different countries needed more participants. And so Amelia Oldfield and I, in two different ways actually in the UK, we managed to get funding for two different studies, but they were both part of Time A. Decided to take part, and we recruited over 100 participants between the two studies. So there's a lot of controversy about the fact that the study didn't necessarily show the things that people had expected. And there are many discussions you can read about that. I would still say that many important things have arisen from that study, and I'm now involved in another study that's another RCT trial, which I'll say something about in a minute. And I think the reasons about this are that there are always things that do show, so that there were some changes in social interaction, but they weren't necessarily numerically significant, but there were some emerging. There was also a qualitative part to the study, and in the UK, a very high percentage, like 90% of the parents, showing through parent interviews and through the further research of people like Laura Blout with Amelia Oldfield and others, showing that the parents had this very positive notion about how the music therapy had helped, especially 3 times a week in the intensive delivery. So I would say what we're doing is finding out certain things, and we may not have found something that is traditionally known as an outcome that can be interpreted and run again and found the same thing, but we might be able to do something similar and find something different. So I think it is becoming more common for people not to, be put off by not finding certain things out. And it makes you think you do need to then examine the different components. But I would say that whilst people were worried, and there's been some articles that have come out of that RCT trial, actually, there's still a lot of evidence being gathered as to the benefits of music therapy for children and families living with autism. There are other studies coming out with different types of outcomes. So I thought I ought to say something about that. Another PhD student, Alexandra Georgiaki in the UK, and other people like Grace Thompson have published some extraordinary valid and really important, I probably left people out, but qualitative research that have come out of the Time A study that is enabling people to understand much more about how music works for that population in music therapy.
I'm glad that you mentioned your large RCT trial, and I do think sometimes we do find out. I mean, that's the beauty of research. We sometimes find things out that we had no idea that we were going to find out. And so it does speak to that whole idea of going into your research, not having preconceived ideas about what's going to happen, which can certainly influence how you interpret results or even how you conduct the study. And again, I think reporting is essential when something doesn't work or doesn't go the way you thought. For me, again, that resonates with one of my research studies where it was based on singing with persons with dementia. And in the first phase, I didn't have statistically significant results. And I looked at, but I had great qualitative material. And the reason was that I didn't really choose the best tests that were going to actually answer my research questions. Yeah. And so I talk about that, and I learned, and I had a follow-up study which was much more successful in terms of the design and more triangulation involved. So I do think it's important, and we learn when the results surprise us. What is it like to work with such a dynamic international team? I mean, you've researched with, you have done such amazing things for our discipline, and you've done some, outstanding research, which has made significant contributions to our field. And you have worked with some other amazing individuals who have very strong names in both clinical work and in research. Can you tell us what it's like to be part of that team?
Yeah, thank you so much. Thank you for that. I don't know. I've been around a long time, so I suppose it's built up. I think it's very exciting. I think that I've learned an enormous amount. I did my PhD actually at University of Aalborg, so I resided in the UK, and that was a real turning point, even though I was very well into my career at that point. And I suppose it gave me a huge introduction to the breadth of what's going on in the whole world, although I already knew from going to world conferences and reading. It was a really rich ground for working alongside people. And I think it's not that it can be challenging. So at the moment, I'm involved in a very exciting RCT trial. I'm leading the UK part of something called Homeside. So there's the protocol of Homeside, the research protocols published in the British Medical Journal Open, led by Felicity Baker from University of Melbourne. So they're leading the whole study, and there are 5 countries involved. So there are 5 universities: University of Würzburg in Germany, the Academy of Music in Oslo. That part is led by Coretta Stanis, and then the other country is Poland, and Ania Bukowska is leading the Polish team. And then we are looking at a comparison of delivering music therapy and word-based reading interventions and standard care, so people not having either, to couples living at home where one has dementia and their carer is receiving this intensive training that's delivered. And in between the weeks that this is delivered, it's delivered 3 times for 2 hours each time, across 12 weeks. In between, there are phone calls, and the people in standard care who are not having either reading or music also have supportive phone calls. But the interventions are being delivered, and in between, the carer is working with their loved one with dementia, using the reading interventions or the music interventions at least half an hour a day, 5 days a week, or they can participate if it's only 3 days, but that's the aim. And we're in the middle of it. And so in the UK, we've recruited 80 dyads, and we're aiming for 99 in each country. And so it doesn't finish till 2022. And that, I suppose, just describing that, it's really rich, and there are cultural differences that we are looking at. I can't say too much yet because we're in the middle, that are very different in countries about types of care, whether care is done mainly by partners, whether it's different same-sex, not same-sex partners, what status the couples have, then whether their main carer is an adult child, or whether it's a friend, or and this is really interesting. Aside from also how people use music and the reading-based interventions differently. So I've just come from a 2-hour UK interventionist supervision group where the OTs and other allied health professions who are delivering the reading component and the music therapists all meet together and present the clinical work. We look at videos, and then every 3 months there's an international meeting separately, one for the music interventionist, one for the reading interventionist. So that in itself is all very exciting. And then obviously it's an RCT trial, so within this there are people, so on our team there's Dr. Ming Su, Dr. Jonathan Poole, who are the trial managers who are gathering intermittently the other data, which is about how people's symptoms and how their issues that they live with dementia change, and for the carer and in the relationship. So we're looking at bonding and about carer competency and how, whether or not having these interventions changes the carer's confidence and feelings of being able to just be helpful and care. I mean, I could say a huge amount more, and you know, we're publishing we've just had another publication in the Journal of Music Therapy.
I'm pleased to say that I've read your recent publication. I'm very much interested in, that's kind of my area of research has been dementia and palliative care. So I, of course, have been following this research, and I think this is an amazing study, and it's an amazing opportunity to really grow viable interventions, viable techniques that can be used for persons with dementia and their caregivers. As we know, by 2050, the amount of people with dementia will double, and it's imperative that we have research like this that, the outcomes demonstrate what kinds of things can be done that are non-pharmacological.
Yes, and in our team, so colleagues Jodie Blosker and Nina Wollersberg and others, we've worked really hard with the participation and involvement groups. So that's the other thing. If you were to ask me what's changed over the years, that is a key thing. And for any study that's designed right from the beginning, the participants or likely participants, or as far as possible, potential participants need to be involved in the design. So we've had a PPI group, as it's called in our country, and there's an international one, and we meet regularly. So we've got people living with dementia in these groups who advise on design and advise at every stage and are really involved. So we've got, I feel that's one of the most exciting things internationally, actually, is also working with people across the world and the similarities and differences with what they are encountering. And we've now got couples who've completed the study who've joined the PPI groups, because it's a 3-year study, and that's even more important. So yeah, you asked me about this international big names, and I suppose one of the things that has changed, I would like to comment on, is the connections between neuroscience and music therapy. And I think that whilst we can see a lot and we can understand a lot psychologically and musicologically by analysing what's going on, it is very important to connect this with the physiology and with the neuroscientific aspects of what's happening. And so I've been very lucky in our team in Cambridge in CIMTA to have Professor Jörg Fachner and Clemens Madoff and others working in this field, but particularly you would know of Jörg's work and looking at the synchrony when two people are making music, and then two people working in music therapy, the therapist and the client, and the work that we're doing in linking with Austria, the Krems team. That is very, very innovative and new. And I'm not personally doing that research, but I'm in charge of the institute where that's happening, and I feel very excited by that. And Jörg is working with people in across the world, in Virginia, I think, and other places, more close to your home. And this work's really taking off in, I suppose, providing the very important data about what is really happening. What is it that's unique about the musical relationship? And particularly that they've started looking at synchrony, and there's one article, and there's others that are following, actually showing some very interesting data where you can correlate what's happening in the room between people with what you can analyze and see happening in the contours from the EEG. So it's not my special field, but I believe in collaboration. So I feel that that's something that's really been important in our research institute, is to link with a holistic approach, I suppose. And I feel, and I would also say to people that in research, doing something doesn't mean that the things you're not looking at aren't as valuable. It's just you might not be looking at them right now. So I think everything, it's like a jigsaw, things then fit together. So you need to look at, yes, the sort of psychotherapeutic and music therapeutic aspects from a more emotionally and socially oriented position. But that can be really strengthened if you know what's happening between these musical brains.
Yeah, I think what you're also talking about really aligns well with the World Federation of Music Therapy and the mission in terms of really growing the international understanding of the use of music as not only as an art, but also as a science. And I think it's imperative that when we publish that we really talk about the music and describe what kinds of music that we're using, as opposed to simply saying that we're using music, because being very specific, I think, will help us in terms of advancing the practice and the discipline as well. And it's so amazing that, to have these collaborations. And as we've said earlier, I think it really is, we're seeing that more and more people are having, collaborations with interdisciplinary teams, and that the research then is not only published in music therapy journals, which is important, but that researchers are also choosing to publish in other allied healthcare, nursing, and medical journals.
Yes, and also in our sort of international centre, we have work happening in the stroke rehabilitation area through Dr. Alex Street's work, and he's linking with people in other countries and trying to get work with that aspect. And I suppose the other thing I wanted to say is, in general, is about PhD and student work. I think that I feel strongly that research should underpin and be crucial to the clinical training. And I know that for someone training to be a music therapist, the most important thing is that they feel comfortable and able to be with the people who are referred to them in the room for the treatment. But the more informed that is by what's happening, especially internationally and especially across diverse populations, the better. So I think there needs to be a continued work towards integration, and it's easy in some areas for these things to get separate and clinicians to perhaps be wary of research and vice versa, and I think that's the other thing that I've seen happen internationally is this integration, and particularly I've seen it in Homeside, this big 5-country RCT trial led by University of Melbourne, because in each country there are PhD students, and they're like a cohort who meet together often, and there are now, I think, between 8 and 10 across the 5 countries, and we sort of coordinate their work. They're looking at sort of spin-off aspects of the main data set. And that happened in Time A as well, I know, and obviously in other studies, but this is what I know about most at the moment. And that is really important. And it's going to change, I think, the field later, but it's also lucky for them that they, I suppose, can be part of, well, I say that, I'm sure there are drawbacks because they're part of this big study, so they might be held back a bit by feeling that they have to do something that's part of this big research rather than their own. But on the other hand, it's a very rich ground for interdisciplinary and intercultural development, I think, in the field.
I'm glad you mentioned intercultural development. I think, you know, intercultural competency is something that is so important and needs to continually be present in our research studies, as well as the design and in our teaching practices.
Yeah.
You've shared some wonderful words of wisdom. You've shared a little bit about your research, and I can't thank you enough for taking the time to do that. What do you have any final words of wisdom for us as researchers, or anywhere that you would like to see perhaps more research being done in our field?
Well, actually, there is a huge emphasis at the moment on fields like people living with autism, people living with dementia, and through the COVID situation, there's people now focusing on long COVID, and I know music therapists are getting involved in really offering something. I think in our country, we've never been as acute, we've never been as rooted in the medical area of music therapy as much as perhaps in the USA. This is a big generalization, but I think in our country we can move more into these different fields. That I mentioned the stroke work, but I also think in other fields like end-of-life care and fields where there is a big medical focus, but there's a very important unique role for music therapy to play. And the one area that interestingly is a major area for music therapists working, but isn't so prioritized in the field of research is there are many areas. One cited the other day by Professor Cheryl DeLeo in one of our roundtables was women's health. But another is actually people living with learning disability. And I said at the beginning of this interview that that's where my interests began in research. But I think we need more research in that field in general. I would say, I suppose a parting point would be to keep researching, but for it to be as related to the clinical experience as possible.
I think that's a wonderful statement to end on, in terms of we definitely need to continue to research to advance our profession. And I do think there is a research study, if anyone is interested to learn more about where music therapists are working, that Kern and Tagg published, I believe one in 2017 and one in 2019, reported the results of where music therapy, kind of the status of music therapy globally, and so where music therapists are working. And I do think it's so interesting, living in Canada, we have not that many music therapists, and so there are many areas where there are therapists in other countries that are working quite intensely where we're not yet. We haven't made strides in certain areas. So I think that's why it's so interesting to learn globally where the profession sits. And I can't thank you again. I can't thank you enough for taking the time to share with our viewers about your work.
Thank you so much. It's very, very exciting, the work that you're doing in the World Federation, and I'm really honoured to have been asked, and I've really enjoyed our discussions.
I enjoyed it as well. Thank you very much, Dr. Odell Miller.